Good afternoon, everyone. Welcome to Ethics for Lunch for January. We'll just give a minute for folks to start arriving. My name is Mark Hughes. I'm co-chair of the Johns Hopkins Ethics Committee and also a core faculty member of the Berman Institute of Bioethics. Both the Ethics Committee and the Berman Institute sponsor our Ethics for Lunch every month. So welcome to a new year. This session is going to be talking about providing information to patients about ECMO, extracorporeal membrane oxygenation. And like other Ethics for Lunch, we'd like to address issues of clinical ethics, things that might be of interest to the hospital community, and have a panel to discuss that, and also invite your comments. You can put those in the chat or the Q&A section. So we can hear from you and get your reactions to the case and to the panelists' comments. Let me have our panelists introduce themselves. So Karen Marsh, maybe you could start. You need to unmute first.
Sorry, I thought I did. Hi, everyone. I'm Karen Marsh, and I am a chaplain at Johns Hopkins Hospital. And one of my units is CV-SICU. So that's why I'm here today.
Adrienne Dixon.
Good afternoon, everybody. My name is Adrienne Dixon. I'm Associate Senior Counsel for Johns Hopkins Health System and the Director for Risk Management for the Johns Hopkins Hospital.
And Caitlin McGeehan.
Hi, everyone. I'm Caitlin McGeehan. I'm a nurse on the palliative medicine inpatient service and former CCU nurse. So work with history of working with families, certainly in different roles on ECMO. And it's nice to be with you today.
And we have both Glenn Whitman and Bo Kim. So maybe you could just each say who you are, what you do.
You first, Bo.
Hi, everybody. I'm one of the intensivists in the cardiac surgical ICU. I'm also the medical director of ECMO.
And I'm one of the heart surgeons, and I'm one of the directors, co-director of the cardiac ICU. And what else am I? And I'm the director of safety and quality for cardiac surgical services at Hopkins.
Great. So welcome to all of our panelists and to our audience members. So our objectives for today are going to be on, I should first of all point out that we're not offering CME credits for this session. We do appreciate your participation, but there won't be any kind of code to text in for CME credit. Our objectives are going to be, first of all, to discuss the importance of informed consent for life-sustaining technologies, things like ECMO. Talk about the development process for the information sheet that we created here at Johns Hopkins Hospital for patients and families so that they could have a better understanding of what ECMO involves. And also review what medically ineffective treatment is and how that might be used with regard to ECMO. So ECMO is a newer technology. It's certainly become more widespread in the past few years. And we created this information sheet to help patients understand the process of if either a patient or it's a family member and their patient is going on ECMO, so that they understand that there's an ongoing process of evaluation for what the ECMO is providing in terms of their clinical management. This information sheet was developed with help from the ECMO program itself, from members in the CV-SICU in cardiac surgery, as well as anesthesiology and critical care medicine and pulmonary and critical care. We had input from the ethics committee and risk management, and also very helpful feedback from patient and family advisory council. So a effort, widespread to really make sure that it was understandable language And later in the presentation, we're going to hear more about the particular details of what we think is covered in this information sheet. We often like to start with a case to sort of situate ourselves. So I'll read through the case and then ask our panelists to comment about it. So this is BF. She's a 60-year-old woman, has a past medical history of diabetes and asthma, and she was admitted to a community hospital with community-acquired pneumonia. She was placed on IV antibiotics and steroids for an asthma exacerbation. And her pneumonia was such that she needed supplemental oxygen. Unfortunately, her lung condition progressively worsened, and she needed to be intubated and placed on mechanical ventilation. In order to tolerate the ventilator, she was sedated, and then she developed signs of adult respiratory distress syndrome, ARDS, while on the ventilator. When that happened, it was decided that she might be a candidate for ECMO, so a decision was made to transfer her to Johns Hopkins Hospital for that possibility. A little bit of background about the patient. She's married. She has 3 adult children who all live nearby. Her family has been actively involved in her hospital care. And once she is transferred to Johns Hopkins, they come and visit her there. Her husband is her surrogate decision maker, and he is approached by the ECMO team to discuss placing her on ECMO while the team is trying to manage her ARDS and other, medical problems. So maybe I could start there with Bo and or Glenn. If you were having this patient and had to present ECMO to her husband, what are the sorts of things that you would talk about with them?
So I could start. So we would make it clear that this is
You muted yourself accidentally there. Someone.
okay. Everyone can hear me. Okay. Hopefully everyone can hear me. What I was saying was, as we approach the husband about the severity of the illness, support mechanism, treatment, modality that may or may not help her in this situation, but it may be life.
Dr. Kim, you and Dr. Whitman may have to swap spots so that folks can hear you in the microphone. And sorry, we missed like everything you said. So do you mind kind of going back to the beginning of your thoughts? Thank you.
Sure, no problem. Can everyone hear me a little bit better?
Now we're better. Yeah, thank you.
Okay. All right. So it may be some back and forth, but what I was saying was that we would make it clear that, first of all, when we're considering ECMO, that all treatment modalities that are more conventional, the mechanical ventilation had been optimized, prone positioning, paralysis, everything had been offered already, and that ECMO is kind of our last resort. So when we approached the husband, we would make sure that he was aware the severity of illness, the gravity of the situation and the prognosis, but that we are offering ECMO kind of as our life support modality, but this may or may not actually help her. It is not treatment. It is strictly for us to try to buy her some time as her lungs recover from her illness. And we also try to emphasize that there may come a time when we decide that the ECMO is not working anymore and that we may have to stop.
And I guess the husband would be asked to sign some sort of consent form.
Yes, that's right.
And we're going to talk about a little bit more that we'd also give them an information sheet nowadays. Could you describe a little bit more about what, how a layperson would understand what ECMO is?
So ECMO is basically a pump. It stands for extracorporeal membrane oxygenation, but really that's it's simply a pump that draws patients' blood out of the venous system, and then it can pump it back toward the venous side or the arterial side, depending on the type of support that's needed. if a patient just has purely respiratory failure, lungs don't work, then the blood is pumped back to the venous side, and it's just providing oxygenated blood to the patient, and the patient's own heart circulation will take that oxygenated blood and perfuse the organs. Now, if the patient has heart and or lung failure combined, then we would use VA ECMO, meaning that the blood is drained from the venous side and then pumped back to the arterial side. And so it will provide richly oxygenated blood to the end organs. And so we can use ECMO to provide end organ perfusion. It's there to augment the heart function, and it can actually take over the heart function if the heart was really failing. And because we're oxygenating it, it can really provide both heart and lung support.
Okay, and so for our patient BF, because it's just a lung issue, she would go with veno-venous ECMO if all the other things have been optimized for her ventilator support and so on. That would be the choice.
We would have to make sure that her heart was working. Hopefully there was an echo at some point. Either that or we could do a quick bedside echo, but as long as her heart function was good.
Okay. And my understanding is that the informed consent also includes language about that there be chaplaincy support. There's a whole team, ECMO team. Maybe Karen, you could talk about if a chaplain were brought in at this point, what support they could provide to the husband, the rest of the family.
Thank you, Mark. Yes. So our role, of course, is to provide spiritual support, but also emotional support. These decisions often invoke a lot of people's theologies. What do they feel? What do they believe about end of life, about the sustaining of life? And so my role is basically to support them in coming to a decision that they feel is in line with their own theology.
And typically, there's also going to be a palliative care consult that is triggered when there's a consideration of ECMO. Maybe Caitlin, you could talk about the role of palliative care for helping with these decisions as well.
Sure. We always appreciate collaborating with the CV-SICU teams in taking care of this patient population. I think, Dr. Kim mentioned it really is a mechanism of support to basically buy the body time to see if the heart and or lungs is capable of healing. And so this takes a lot of patience and a lot of grit on the part of sometimes a conscious patient, and most of the time on the part of the family members and the loved ones who are essentially waiting to see if this is going to be effective and help turn things around for their loved one. And so a big part of what we on the palliative medicine team do alongside chaplaincy is support the patient and the family. We do offer anticipatory guidance. As Dr. Kim mentioned, we want patients and families to understand the gravity. We want them to understand that to this point, everything conventional that we have to offer has been done. And so it's important for them to understand that in some respects, this is sort of a heroic, attempt at helping the body heal. Because a big part of what we do on palliative medicine is making sure that whatever we're doing to or for a patient is really in alignment with what their goals are. And two, that we're helping to support patients and families in making decisions that may be initially sort of beyond their understanding or comprehension. So we're helping to bridge that gap between the care team and the families and understanding exactly what's happening and what may come as a result of these decisions that they're making. So there goes a lot of support and conversation, ongoing conversation with these cases. And, it's a process. You don't want to drop everything at their feet all at once because it can be terribly overwhelming. And certainly people who are supporting loved ones on this on this therapy are overwhelmed, perhaps they're in shock, perhaps they're exhausted. Some people this happens very quickly, and some people, their loved ones have been in the hospital for weeks. So you kind of have to meet them where they're at. But palliative medicine is there to support, aid in communication, aid in anticipating what may come, and certainly be part of those goals of care conversations, perhaps when the body doesn't recover, and what then?
So there could be a wide range of reasons that a person might be a candidate for ECMO. Bo, do you want to comment on any of these or highlight any of the particular indications for ECMO?
Mark, can I show something? Can I just show something?
Please.
Am I allowed to have am I allowed to get control of the I want to control the request remote control.
What do you want to look at?
The previous slide. I don't know how sophisticated everybody on the phone is, but I just want to point out what's going on here. Can you see my pointer?
We do not, but I can point if you just guide me.
1 second, maybe I can. Gosh darn it. Okay, put your pointer on the right heart. Right there. Okay, so that's deoxygenated blood. Let's follow it down and see where it's going. It's going through some tubing. It's going into a pump, going through an oxygenator, going back in. And now, although it doesn't show it, it's actually going to go into the right heart and make the right heart red. And now blood's going to get pumped from the right heart to the left heart. Just that little distance there. But it's going to go through the lungs to get there. But the lungs don't matter anymore because the blood's oxygenated. So you could take the lungs out of the circulation. It doesn't matter. And this leads to one of the dilemmas, because if the lungs don't heal, it doesn't matter, because the patient's on ECMO and they can have great oxygenation with no lungs. Or if the lungs take forever to heal, you're sitting there not knowing when they're going to heal. But the patient's doing well on this oxygenator that's sending oxygenated blood through the lungs into the rest of the body. And the reason I'm going through this with everybody is, oh, and I missed the third scenario. You do this, the patient does well, doesn't die, well perfused with oxygenated blood, but the lungs don't heal. The lungs fibrose, they scar, they cease to be functioning. Meanwhile, the patient's doing fine, getting lots of oxygen. It doesn't matter that his lungs don't work. And this is where we get into the dilemma of what do you do then? And how do you know they're not going to get better? By waiting even longer. Okay, that's what I wanted everybody to see.
It does potentially highlight where you might decide against ECMO. So you're waiting for the lungs to recover, or you're waiting for the person maybe to be a transplant candidate to give him new lungs. But there are certain exclusion criteria for ECMO. Do you want to comment on these, Bo, how these were created, or the rationale behind some of them?
Yeah, so I think you saw on the previous slide some of the indications, and really all the indications were generally VA ECMO, heart and lung support. Only one really is lung support alone, which is the pulmonary failure. Some of these were, ECPR, ECMO being used as part of advanced life support or ACLS. And but these exclusions, I would say, we've debated about these exclusions in our program multiple times, in either to keep them more restrictive or try to expand its use and expand the indications. Usually, though, it's based on data that suggests certain criteria is associated with worsening survival, such as the number of days on a ventilator, patient's age, or multi-organ failure. And so all of these things are associated with worse outcomes, and we do not offer ECMO when any of these criteria are met.
I guess one of the questions, and the reason we created this information sheet was because we had patients on ECMO for longer periods of time, because with COVID, there was the possibility that it may take longer for the lungs to recover or to see what the outcome of the patient would be, which then raised questions about allocation of a scarce resource. So there was development of a algorithm for ECMO support in the setting of resource constrained and need for allocation. So we had a working group on this, and it was published in Chest. Can you comment a little bit about how the triage plan came up, either you or Glenn or others, about how it was decided of when we might choose to take a person off of ECMO? Maybe just a little bit about those details, and I can go through other slides about the process.
I think the times when we had with bed capacity was, and during the pandemic is when we ran into bed shortage. Normally, we do our best to accommodate, especially our internal patients, but we do have to understand that these beds are shared with the cardiac surgery ICU, and so beds taken away for ECMO is a bed that can be used for post-operative patients. Now, this triage came about because the demand was certainly way greater than our bed availability, and we thought that there had to be a way of selecting the patients that would really benefit the most. I have to say that we really had to streamline this process. We couldn't run into the issue of patients emergently needing ECMO, and we were waiting for multiple people to get on the phone. And so it really came down to screening by an intensivist and a surgeon, and then that was if a patient was deemed acceptable for ECMO, we just had to get that cleared by a hospital bed manager, and that was usually either through medicine or someone that's equivalent to central intensivist. But it was not to that degree of detail that we were ever able to triage these ECMO patients. Now, as far as the back end of identifying patients that are no longer have a reasonable chance of recovery, that's a little bit of a separate issue. But if we're going to turn our discussion in that direction, I would say that there have been a number of patients, especially in the COVID era, where everyone that was involved in the patient's care thought that the lungs no longer had a chance of recovery. Now, exactly how long we provide ECMO support, how many days, is really an unknown. And we really learned a lot from COVID. It used to be after about 2 weeks, we would usually take someone off for pure lung support. But since COVID first surge, it was about 28 days on average. And then after that, it was about 45 to 50 days on average on the second and third surges. So we were offering ECMO for longer and longer periods of time. And then identifying those patients who we thought really no longer had a chance of recovery. And we were having family meetings, talking to family members pretty much every day, having weekly meetings, and trying to determine when we can come off. That was the real challenge. And born out of that challenge, we understood that the consent process is imperfect. I don't think that the family members really did understand what ECMO technology was, and they really just heard there's a technology that could potentially save their loved one's life. And they were, of course, going to sign on board despite the risks and despite us explaining that there may become a time when we may have to stop. Whether they heard that or not, it certainly was not something that they oftentimes was not always amenable to that. So I think because of that need, Glenn and I and a team came together and came up with the second document that we were going to provide to all patients' families to explain again that what is ECMO and there may come a time that we may have to stop. Did you want to comment more about that?
Maybe before we turn it over to Glenn, maybe so if we're talking about a patient on for a couple of weeks or several weeks, perhaps come back to Karen and talk about how to provide support to the family when there's this uncertainty about what's in store for their loved one. Could you say more about how you would be meeting with the family or talking with the family or praying with the family in this sort of protracted course on ECMO?
Yeah, well, there are two main issues, right? There's the theological question of, God's will. Is this God's will? And are we doing God's will? Of course, there is the emotional question of, well, we really want to do everything we can for our loved one. We want them to live, but we don't want them to suffer. And so that is, even though patients are sedated many times, there's still this great concern, are they suffering? And it's very difficult too, when you go in as a family member to see your loved one in this state, and you have memories of them, walking about and doing all the activities that they would do. And so this whole sight can be very shocking because, again, the quality of life issue. And the idea, whether to go on ECMO or to be taken off of ECMO, the idea of potentially being part of a decision that might have changed this person's life, if not taken their life in the end, is just very hard on the care decision maker and the family member. So a lot of times what I do is I will explore their feelings with them, try to connect that with their own beliefs. And if the patient is not able to speak, then I will speak to the family about what that patient believed and how important was their faith to them. And perhaps, and this sort of crosses over into palliative care too, and oftentimes I'll work with palliative care. We're trying to determine, basically what they think that patient would want. And this is all based upon the theological side of things, connected to, again, with many Christians, they are concerned about the will of God and doing the will of God. So, but that's applicable to other faith traditions as well. So again, trying to speak to them deeply, listen to them about their feelings and their beliefs, and help them to identify a path forward. And then, of course, giving comfort. Prayer is always a big part of my job, especially in these situations. I will often pray with the family members and the patient for discernment and for comfort, knowing that they're doing the best they can for their loved one and for themselves.
Caitlin, you also have the perspective of being a bedside nurse in these situations besides the palliative care role. What's the perspective of the nurse taking care of a patient in the CVCICU?
Yeah, I was eager to talk about that. certainly they are day in and day out, long days taking care of these patients, often multiple days in a row and over time. And so, in a lot of respects, they kind of, the nurse at the bedside is able to identify in some ways whether a patient is doing better or worse on these therapies, sometimes more readily and earlier than other members of the care team. Sort of the nursing gut, so to speak. But it's difficult and it's emotionally draining. And it's also, it's an exhausting nursing care that's needed for these patients. These patients are wholly dependent. They're often paralyzed. They're certainly usually sedated, not always, but every move, everything is a fine-tuned, well-oiled machine in that room. And so it requires a lot of attention and accuracy and physical intensity to take care of these patients. And so, as a palliative nurse, one thing I was going to speak to is, as much as we can offload the nurses at the bedside in terms of communication and conveying thoughts, ideas, discussion to the families, as well as the care team, we like to do that because, while the care team is, focused mostly on the medical management and the mechanical management of these patients, the nurses are focused obviously very much intensely on providing the nursing care. We have the luxury of being able to have that full-time attention on the patient and the family in terms of really in the very beginning, conveying the gravity. And, I think one of the challenges that we can all relate to is during the time of COVID, when family members weren't able to visit to the bedside. It was this major challenge of, trying to convey over a phone call with sort of a faceless person on the other end, how sick, how truly sick their loved one was. And, while we don't want to scare anyone, we don't want to intimidate, we don't want to, constantly be ringing the alarm bells. We want to thoughtfully and with sensitivity really work on very early on conveying the gravity. The last thing we want is anyone to be shocked at the loss of a loved one, weeks and weeks into a course of ECMO. And so a lot of it is talking in a sort of stepwise fashion and developing that rapport and the relationship. And then really just this collaboration. I mean, the fact that we're all here on this call, this really is almost, if we were on a Zoom call with a family, this is what it would look like. We would all be, kind of representing our various scopes and offering comfort and a realistic outlook to the family. But yes, very, very stressful for the bedside nurses, and kudos to them for taking such loving care of these patients.
Mark, I wanted to say that when you had one of the slides up that talked about the triage process. Bo, correct me if I'm wrong, but we never needed it. We recognized that we could come up with around 18 circuits if we needed to. I think it's maybe the greatest number of people we ever had on were 8 or 9 people at the same time. We never faced a situation where some end of life 65-year-old receiving what at this point was futile care without the family agreeing to stopping, was using up a bed that a 24-year-old who just got COVID and had his whole life in front of him could need. That never happened. We wrote the document just in case it might happen, with a committee that would help make a decision about what to do, but that didn't happen. And we all realized that if our beds got full and someone was really sick, we could transfer them out. And furthermore, the entire region met every Wednesday so that we'd all know who had open beds and who didn't. who could accept transfers and who couldn't. So I just wanted to clarify that.
Do you think the experience with long COVID, or these patients with, protracted courses in the CV-SICU changed how ECMO is done nowadays? In terms of,
Absolutely. It changed it so dramatically. Not so much for VA, because very, very few percent, like less than 5% of COVID patients went on VA ECMO. But what we realized, as Bo pointed out, was the following, that up until COVID, the average number of hours that a VA ECMO patient was on ECMO was 120. And for VV ECMO, it was 240. That's 10 days. That was the average, 240 hours. But with COVID, we started realizing that you could be on longer, that when it was a unisystem disease, we didn't just say at 10 days, it's over, because the patient would be fine otherwise. And we kept going longer and longer and longer. And I can never forget a young lady who survived. I think I was taking over for Bo on the 42nd or 43rd day, during which time her tidal volumes, I'm going to exaggerate, had been 40 cc's with a per breath. And then all of a sudden on the 43rd day, it was 100 cc's. And then the 44th day, it was 150. And by the 58th day, it was 300. And now we're talking about after 8 weeks, 6 weeks, 7 weeks, 8 weeks, we're talking about, holy mackerel, her lungs have recovered. This might work. And then this happened, not just to us, but it happened around the country, that all of a sudden 60, 70, 80 days, over 100 days, people were surviving and their lungs were, having not been functioning up until then, would all of a sudden start to recover. So it, in a way, it's lowered our threshold for putting a person on ECMO, and it's diminished the threshold. And it's raised, what did I just say? It's lowered the threshold for going on, and it's raised the threshold for coming off.
so you might keep them on longer nowadays for even non-COVID patients.
Because we know
Exactly.
these lungs can recover.
Mhm. Which leads to these difficulties with shared decision-making, because there's going to be a lot of uncertainty as to whether the lungs will recover, whether it's just a unisystem disease, and maybe if you do a lung transplant, or they reach a point where you decide that it's going to be medically ineffective to continue the ECMO, which led us to create this information sheet to sort of lay out these possibilities. So maybe Adrian, you could speak to why we thought it necessary to have an information sheet in addition to the informed consent document.
Yes, thank you. From my perspective, I think a lot of people, when they think of risk management, they sort of think of our office, becomes and gets involved in response to, an untoward event that reached a patient. But really, some of the best practices and the strongest interventions that we can put in place from a risk mitigation standpoint is trying to be proactive and sort of preemptive in certain situations. So, in terms of looking at, as we transition into the development of this ECMO information sheet, a lot of times in our office, what we have found is, when patients and families, especially during these very high criticality, sort of high emotional, high stakes types of situations related to a loved one's overall care and treatment, the more information we can provide up front, the more information that we can share as it relates to possibilities, and the more that we can provide things that are sort of tangible, or where maybe an emotional kind of shock response, provider, telling you, sort of like a soup full of bowl of information all at once during, learning about a devastating sort of diagnosis. Patients may, or family members may sort of forget everything that was shared at that moment of shock. What we have found is just, having a tangible piece of paper that patients can and family members can go back to refresh recollections, and to ensure that, folks kind of were aware of the expectations and are aware that, the system has a uniform and standardized approach to looking at interventions that are provided to our patients. What we have found is that helps to minimize conflict between family members who obviously are going through, a lot, dealing with, their loved one, and the clinical team that's trying to, provide care and treatment and help patients. And so this, I think, was some of the overall genesis into, a multidisciplinary group coming together to put everything on paper so that family members could have upfront and know what they could expect outside and apart from the procedural consent, which is a whole nother pathway and process as it relates to, a patient receiving this type of intervention. But just in essence, giving everyone equal playing field to readily appreciate what they can expect. And also, if the treatment is not working as hoped for, also what family members can start to expect from us in that sort of circumstance as well. Because we had seen circumstances where there is this overall, conflict, whether it's, from a religious standpoint, you're seeing somebody do well and then they don't, and sort of changes back and forth clinically. That sometimes it did create some types of issues between the clinical team and the family. So with that, I'm going to stop talking and we'll kind of go from there and see what the sheet looks like.
Yeah, Glenn or Bo, do you want to comment also about the rationale for creating this information sheet? Anything to add to what Adrian said?
Not yet. Let's talk about whatever points you wanted to raise about this information sheet. I think, Bo, you can certainly comment, but I'm dying to point out what we want out of this sheet and what we don't get out of this sheet.
Okay,
But
well, we'll go through each of the 7 elements here, just to highlight and have any of the panelists comment on them. So the first is that we obviously want to provide them information, but we're going to have documentation of who was in the meeting, the original meeting. So there might be an informed consent at the very beginning. Generally, it's not going to be the patient that signs that because often they are intubated and sedated and paralyzed. And so it's usually a family member. So we made a point on this information sheet to document who's actually receiving the information. Anybody want to say more about how that would work, of how you'd have these initial meetings with the family member? All right, well, we would have the meetings and document who received the information. There'd be a paragraph on, just trying to explain in layperson's terms what ECMO is. And then there'd be a fill-in of what the particular condition that the patient had for why they're receiving ECMO support. Anybody want to comment on this section of the document?
Only to say that to explain to a layperson what we just explained at this beginning of this meeting, what VV ECMO is, I think that we're kidding ourselves to think that the average patient's family has any idea what they just heard. Even though it seems so straightforward to me, it's not. And 2, it's incredibly time consuming. Okay, that's what I wanted to say.
And you need to devote that time. Yeah. I wanted to bring out 3 points. So the third sentence, it says, it is not a therapy or treatment. So Bo, I think you had mentioned this earlier, that this is really a support, but it is not an actual treatment. And there was wanted to really make clear to families that while it may be used for a period of time, it's not a particular treatment. Do you want to say anything about that idea of a bridge to another therapy, as opposed to it being a treatment in and of itself?
Yeah, so being on ECMO doesn't do anything for your lungs. The one thing that we can do is really turn off the ventilator so that the ventilator does not induce any more injury. And so by that method, the lungs have a better chance of healing from the injury that has already occurred. But ECMO by itself is not a treatment. It's not a therapy. And actually, if for heart failure, if we were to put someone on VA ECMO, the ECMO actually can actually prevent the heart from healing if we don't manage it correctly. So again, it's just to bridge us to either recovery, give the body chance to heal, or it's a bridge to some other more advanced therapy like a transplant, or a mechanical device that's more durable, like a VAD, which is a ventricular assist device for the heart. But there's no replacement of the lungs, unfortunately. So it's either recovery or transplant in that case.
You know what? You know, the other thing about this document is, I don't know whether it's in this paragraph or not, but it says, yeah, it's there. And that unfortunately, even with our use of ECMO, it's possible your or your loved one's heart or lungs may not recover. So I've only used this document 3 times. And every time I read it to the family, I say to myself, do we really ever think that I'm going to be reading this to a patient and that they're going to understand this? Now, maybe other people on this call can figure out how that would work. But at least as I've used this document in the cardiac ICU, the patient who's getting it is not in any way capable of, the patient who's getting ECMO is not in a situation where you can talk to them. And even afterwards, you can't talk to them and go through this. Maybe weeks later, they might get to the point where they can understand what's going on, but not for the first several days. They're too sick. So this is really all for the family. And we don't have to change it, but it just doesn't feel true to me when I'm going through the document and I'm reading, it's possible you or your loved ones. It's not it's always your loved ones. And I feel like we should change the document to say your loved ones. It's not the patient who's going to be receiving this information. At least not the way this plays out in real life.
Now, another point that raised some controversy when we were working, both within the ethics committee and the Patient and Family Advisory Council was the last sentence that says, despite the support that ECMO can provide, death may occur. So pointing out up front that, this is heroic measure. It's still possible that the person might die. Any of the panelists want to comment about that particular feature of actually saying, it's possible that your loved one could die even with this advanced technology?
I mean, I will just say from my perspective, when our office tends to get calls, and then we work very closely with our ethics colleagues when there's conflicts between, the clinical team and the patient's either legally authorized decision maker and or host of family. Maybe that folks are not in alignment of expectations. I think that this last statement does help to level set expectations because a lot of times, family members, legally authorized decision makers, they come in with a lot of hope, which I think is amazing. And there's something to be said about having hope in the midst of a storm, if you will. With that said, and again, sort of talking about, as I shared previously, being proactive, ensuring that folks are aware of what potentially they can expect, including up to and including death, on this form, as well as on the procedural informed consent form and the conversation that ensues within that. I think it's critical that caregivers and legally authorized decision makers recognize and are provided this information repetitively, because the times that we have been engaged, it's been more so that, well, I didn't know. If I'd known, or this wasn't what I expected when my loved one initially was on ECMO, or was placed on ECMO. So I think it is critical to have these conversations and to discuss this as frequently as possible, just because, again, as what I shared previously, there are times that the family members, just through being overwhelmed with all the decisions having to be made and everything that's happening, and not just with the patient, but maybe other external kind of forces outside of the hospital that a caregiver, a legally authorized decision maker has to manage. Things sometimes get lost in memory, or certain things folks don't readily recollect. So those are my 2 cents. Does anybody else have any other comments about that?
Yeah, when I consent a patient or advise a patient's family, I never consent a patient. When I advise a patient's family about what just happened or that the loved one's going to, I always include the fact that there's across the board for all patients. So 1 out of 2 times not going to. The other thing I wanted to point out.
You may need to come closer to the mic.
Did anybody hear what I just said?
Glenn, give that statistic one more time that you just
That
stated.
if you look at all people who go on ECMO, 50% of them don't survive. And if you look at people who go on ECMO after open heart surgery, 75% of them don't survive. And what I wanted to say is something that I neglected to say when I said, when am I ever talking to a patient who can listen to this? I never am, is because that portion of this information, it was written for people who are, for surgeons who are consenting patients who might get into real trouble during surgery at a time when they are competent, and telling them, if you don't get through this operation in a way that you can support your own heart or lungs, I want you to know that there's an option of putting you on ECMO. And now, in fact, when in that situation, it's possible your heart or lungs may not recover. That all makes sense. But when you're talking about a family whose loved one just got put on ECMO, a part of me thinks that we shouldn't be trying to get two uses out of this one document as I'm using it more and more frequently.
Any other comments about this particular part of the section? All right, well then we say that there's going to be a period of reevaluation. Can you comment on the usual time frame for seeing how ECMO is working? And there are these 3 points of, is it continuing to be helpful? Do we see signs of improvement, or are there possibilities of alternative therapies? The time frame for reevaluation, Bo?
So anyone who goes on ECMO, we try to call the family pretty much every day. Then a formal meeting should happen on and kind of a much more broad, including extended family, that should happen either the 3 or 4 week mark. We try to, at the very least, have updates on a daily basis, and then more of a goals of care discussion on a weekly basis, and then really that 3-week or 4-week mark is really just to say what are our options going forward at this point. If we see no more improvement, do we keep going, or we say there's more deterioration? Is it reasonable to stop? We just kind of lay out all the options for goals of care.
And still a shared decision-making process there. And so the decision to whether, to continue it or to consider stopping it. And we'll identify who the authorized decision maker is if it's a patient that lacks capacity.
Mark,
Go ahead.
one comment just in terms of the content of those meetings, especially that 3 to 4 week mark and sort of the week to week milestone meetings. It's, a lot of these patients, as we've mentioned multiple times, are single organ failures. Lungs are the organ system that's most in trouble. But it's not good for anyone to lay in a bed for days and weeks, at a time, with compromised nutrition, no movement, a lot of their very fundamental sort of bodily functions being different in some way. And so part of, from my perspective, what needs to kind of start to come into these conversations week after week after week is drawing attention to some of those more sort of fundamental bodily functions and not ignoring the fact of how a body can slowly deteriorate over time, even if the kidneys are still making urine, and even if we would lighten sedation and they would be able to squeeze our hands, and even if we have a sense that their heart function is still tolerating the ECMO support, and we haven't had any other problems occur, just laying in the bed and having artificial nutrition and lack of movement is incredibly damaging for someone. And so I think making sure that as palliative, certainly we kind of help to continue to adjust families' understanding of really the overall global state, health state of that body that is having to go through days, weeks, and sometimes a month or two of ECMO therapy.
And that is exactly, I think, a question that one of our participants raised. I think it was Dr. Berkowitz, and I think we do talk about this a little bit more within the document. So, Dr. Hughes, so I don't know if you want to comment on that or just share the other points.
Well, the sentence that says, the final decision is made by your physician or ECMO team. So while we have this goals of care discussions and maybe the weekly updates and trying to get input from the family and give them information about how things are going, it makes it clear that it's ultimately the ECMO team that makes the decision about whether it's going to continue or not. And then, the other sections that we provide the support to them. So we've already mentioned maybe social work, chaplain, palliative care, the ethics consult service available to assist the family through these, difficult times while their patient is sick. And then if there is a disagreement, so that the audience member, said, well, what if the family disagrees and wants to continue it, and the team is saying it needs to be stopped? This is where we would call in for an ethics consultation, either at the family request or at the team's request. And then, the last part of the document that we're making sure people are receiving this information and being able to comment on it. Maybe in our last minute, the panel can talk about, so what if there are decisions to discontinue ECMO support? How would that unfold? Who would make that decision? How would it be communicated to the family or to the patient? Bo, do you want to comment on that?
Yeah, so once we determine the patient is not going to recover, and that is a bit more complex than simple looking at the lung function or looking at the CT scan. But especially if there is irrecoverable damage to the lung. There's been diminishing lung function over the course of a month. Then we start to have the conversation of goals of care, and we still want to include the family members. And we explain to them that there is a chance of recovery despite the patient being stable on this ECMO support. And have encountered on a number of occasions a lot of reluctance, a lot of resistance from families of taking someone off ECMO, especially when the loved one looks as stable while they're on life.
And there just may be times where we invoke that it's medically ineffective, that we've reached a point where it won't prevent or reduce the deterioration in the health of the individual or prevent their impending death. So that might be invoked. Adrian, do you want to comment on any aspect of this where it is a team decision to discontinue the ECMO support?
Yeah, other than just to say that again, I think level setting family expectations, having series of conversations, active communication, consistent communication, in a timely manner. I think in most cases, we are able to come to consensus. And I think the family can also get to where the clinical team is to agree that the ECMO intervention is medically ineffective and that it's time to discontinue the intervention. But with that said, there is the legal, the law, the statute. We have policies that within the entire organization sort of outline how to implement medically ineffective treatment. But we do have support from our jurisdiction or our legislature that helps us in circumstances where there may be conflicts and family members aren't able to get to that space where our clinical team is not legally required to continue to provide a treatment or intervention that obviously is not going to change more so in the improvement trajectory a certain situation. So that's when my office and ethics will kind of get involved to help to support the clinical team, and then also obviously to help to support the family who's just going through a very difficult time. Sometimes it does take time to get to that place of acceptance, and for the most part, I'm pleased that we're able to get there. So, does anybody else have any comments?
Any final comments from anyone?
Yeah.
Karen, you wanted to have a
Yeah, I just wanted to say that that's a key role of the chaplain, is to help the family with that process of acceptance, as well as all of you on the team are helping them come to acceptance. My angle is just from that theological, spiritual point of view.
Yeah, so hard decisions and wonderful technology, but lots of uncertainty and figuring out how to navigate through it. So I think we'll end it there. Thank you to our panelists for a great discussion. Thank you to our audience members for coming, and we'll see you next month.
Thank you, everybody.
Thank you.